let's unpack this. Welcome back to the deep dive. Today, we are opening a file that I think, for a lot of people, has been mentally filed away under inevitable. We're talking about osteoarthritis, or OA.
It's the single most common joint disorder globally, and you're right, that mental filing system usually labels it as, grandma's bad knee or simply the price of getting old.
Exactly. The cocktail party definition is always, I drove the car too many miles, the tires are bald, the tread is gone. It feels like a mechanical failure.
Your simple wear and tear.
Right. Passive, irreversible. It's just gravity winning in the end.
That is the prevailing narrative, the wear and tear model. But if there is one thing we need to dismantle right at the start of this deep dive, it is that idea. Because when you look at the actual source material, the clinical breakdown of what is happening inside that joint, it is not passive at all. It is a highly active, complex, biological battleground.
Battleground. That implies there are two sides fighting.
In a way, there are. It's your body's own repair mechanisms fighting against a breakdown process that has, well, spiraled out of control. It involves inflammation, cellular hyperactivity, bone remodeling. It's a lot more than just rubber wearing off a tire.
Okay, so if the bald tire analogy is out, or at least insufficient, we need a new mental model.
Yeah.
So what's our mission for today? What are we trying to build for the listener?
I think we have three main objectives to get through. First, we need to map that biological battlefield. We really need to zoom in to the cellular level to see why the cartilage is actually breaking down, and, maybe surprisingly, how it tries to save itself first.
That part was a huge surprise to me, the idea that the joint actually fights back.
It's absolutely crucial to understanding the disease. Second, we are going to decode the treatment hierarchy. It's not just take a pill for the pain. There is a very specific order of operations, from lifestyle changes to a surprisingly complex decision tree for medications.
And I know we have some serious aha moments coming up regarding drug safety. Specifically, that trade-off between swallowing a pill versus rubbing a cream on your knee.
Yeah.
That section really changed how I look at the medicine cabinet.
It's probably one of the most actionable pieces of information for anyone over the age of, say, 75, or really anyone with a sensitive stomach.
And finally, we're going to look at what doesn't work, despite the fancy marketing and what you might see online.
The myth-busting section. Always a favorite.
All right, let's dive into part one, the biological battlefield. You said this isn't just wear and tear, so if it's not a car tire, how does the story actually start?
It starts with an insult, a damage event. Now, this could be an acute injury, like tearing a ligament in college football. It could be chronic instability, where the joint is just wobbling around too much for years.
Or it could just be physics, right? The loading.
Exactly. Excessive loading, often from obesity. This initial damage targets the articular cartilage.
Okay. And in the old analogy, this is where the rubber just gets scraped off, and that's the end of the story.
But that's where the analogy completely fails. In a tire, the rubber is inanimate. It's inert. In your joint, the cartilage is alive. It's full of these cells called chondrocytes. And when that damage happens, these cells don't just, die quietly. They wake up.
They wake up.
They detect the damage and they become hyperactive. The source material is very specific about this. Initially, the activity of these chondrocytes increases. They are frantically trying to synthesize new matrix constituents, new cartilage material to patch the hole.
So the body is literally trying to fix the pothole while traffic is still moving over it.
That's a perfect way to put it. And in the early stages, this frantic repair work can actually cause the cartilage to swell because of increased water content and synthesis. It's a full-on rescue mission.
But obviously, since we're talking about a disease here, the rescue mission fails.
It does. And that's the tragedy of OA. The rate of damage eventually and inevitably outpaces the rate of repair. The tipping point is reached.
And then what?
Then the cartilage begins to soften. It develops these vertical cracks, a process called fibrillation. And eventually, you just lose enough cartilage that the underlying bone is exposed.
And that's when we get to the bone itself. I think most people, myself included, assume the bone is just the passive victim here. The cartilage disappears, so the bone gets rubbed raw. Simple as that.
It's so much more sinister than that. The bone underneath what we call the subchondral bone, it undergoes pathologic changes very early in the process. It starts releasing chemicals, things like vasoactive peptides and enzymes called matrix metalloproteinases, or MMPs.
Matrix metalloproteinases. That sounds like a demolition crew.
That's exactly what they are. They are enzymes that break down proteins, so the bone, the very foundation, is releasing chemicals that are actively helping to destroy the cartilage right above it.
It's like the foundation foundation of the house is releasing a toxic gas that just eats away the floorboards.
A vivid image, but yeah, it's accurate. And on top of that, you get something called neovascularization.
Which means what in plain English?
New blood vessels. They start to invade the bone and cartilage where they absolutely should not be. This increases permeability and it just accelerates the damage. The bone isn't just sitting there taking a beating, it's actively participating in the joint's failure.
Now, we have to talk about the most famous visual of arthritis.
Hmm.
The bone spurs. The osteophytes.
Yes. The absolute hallmark of the X-ray.
I've always thought of bone spurs as just random junk.
Yeah.
Like barnacles growing on a ship hull because it's old.
Yeah.
Just calcified errors from the body.
And that's how most people see them. But the text offers a really interesting perspective on this. These new bone formations, they usually happen at the joint margins, so distant from the actual point of destruction. The prevailing theory is that the body is building them to help stabilize the affected joint.
Whoa, wait a minute. So a bone spur is the body trying to build its own brace.
Precisely. The cartilage is gone, the joint is wobbly and unstable. The body senses this mechanical instability and it says, okay, I need to lock this down. So it grows extra bone to widen the surface area and limit the painful motion.
It's a functional adaptation then, not just a mistake.
It is. It's a desperate attempt at achieving stability, even if the result for the person is pain and a loss of flexibility. The body, in that moment, prioritizes stability over mobility.
That completely changes how I view those knobby fingers or knees you see on people.
Yeah.
It's the body trying to save the joint by essentially freezing it.
Mm-hmm.
Now, you mentioned inflammation earlier. I usually associate really heavy inflammation with rheumatoid arthritis, not osteoarthritis.
And that is the classic teaching. OA is often labeled non-inflammatory arthritis to distinguish it from the autoimmune firestorm that is rheumatoid arthritis. But that's not strictly true. The source material clarifies that inflammatory changes can and do occur in the synovium, which is the lining of the joint.
So what triggers it? And it's not an autoimmune attack. What's causing the swelling?
Debris.
Debris.
Literally. Crystals are little shards of cartilage that break off and float into the synovial fluid. The immune system sees those shards and it reacts. It treats them like a splinter.
And then the chemicals come.
Exactly. You get all these chemical mediators flooding in things like interleukin-1, prostaglandin E2, TNF-alpha. This causes the synovium to thicken and creates what we call effusions or fluid buildup. That's the swollen knee.
So it's a vicious cycle. The cartilage breaks, the shards cause inflammation, and then the inflammation releases chemicals that cause even more damage.
Correct. And broadly, we can categorize all of this into two main buckets, primary and secondary OA.
Let me guess. Secondary is when we know what caused it, like
Yeah.
an old injury.
Right. Secondary OA is associated with a known cause trauma like that football injury from high school or a metabolic disorder or even congenital factors where, say, the hips didn't form right at birth.
And primary, what does that mean?
Primary or idiopathic OA is the most common type. And idiopathic is really just fancy doctor speak for we don't know the exact starting gun. It arises spontaneously, usually associated with aging and genetics, but without one specific triggering event we can point to.
Okay, so we've established that the biology here is active, messy, and self-perpetuating. It's a real fight. So let's move to part 2, what it looks like. The clinical presentation. If I'm a patient, what am I actually feeling day to day?
Well, the predominant symptom is, of course, pain, but it's a specific signature of pain. It's described as a deep, aching pain. And the hallmark is that it accompanies joint activity and it decreases with rest.
So the more you use it, the more it hurts. When you finally sit down, it eases up.
In the early stages, yes. As the disease advances, it can hurt at rest too. But there is another rule that is absolutely critical for diagnosis, and it has to do with stiffness.
The morning stiffness rule. I saw this in the notes. This seems like a really important differentiator for people trying to figure out what's going on.
It is huge. Patients with OA will often wake up stiff. Their joints feel almost gelled up. But, and this is the key, that stiffness typically lasts less than 30 minutes.
Less than 30 minutes. Why is that specific time frame so important?
Because in inflammatory conditions like rheumatoid arthritis, that morning stiffness lasts much, much longer. An hour, 2 hours. It can take half the morning to loosen up. In OA, you get up, you move around a bit, and within 15 or 20 minutes, that gelling sensation resolves. The duration is a major diagnostic clue.
That is a great takeaway for listeners. Watch the clock when you wake up. What else? What other symptoms?
Mechanical symptoms. You might hear or feel something called crepitus.
Crepitus, that's that crunching, crackling sound, right? Like there's gravel in your knees.
Exactly. It's the sound of rough, damaged surfaces rubbing together. You also get a limitation of motion. You just can't bend the joint as far as you used to. And in the lower extremities, a feeling of instability. Patients will often say their knee feels like it's going to give way or buckle underneath them.
Now, what about the visual markers? I know when people think of arthritis in the hands, they think of those knobby fingers.
Yes, and those knobs have specific names. In the medical world, location is everything. If you have bony enlargements on the joints closest to your fingertips, the distal interphalangeal or DIP joints, those are called Heberden nodes.
Heberden at the fingertips. Got it.
And if the enlargements are on the middle joints of the fingers, the proximal interphalangeal or PIP joints, those are called Bouchard nodes.
Heberden and Bouchard. It sounds like a stuffy law firm. But these are essentially those osteophytes, those bone spurs we were talking about earlier.
That's exactly what they are. They are tangible, visible proof of that bone remodeling we discussed. And if you touch the joint and it feels warm or looks red or is tender, that suggests that inflammatory synovitis is active at that moment.
Okay, so we have the patient story, the physical exam, but how do you officially diagnose it? I feel like everyone expects some kind of high-tech scan. Is there a blood test for OA?
Not really. In fact, having normal labs is actually part of the diagnosis. The American College of Rheumatology, or ACR, has very specific criteria. It's really a mix of history, exam, and standard x-rays.
Walk us through the math here. Let's say I come in with hip pain. How do you confirm it's OA?
Okay, for a hip OA diagnosis, you need the hip pain, obviously. Plus, you need two of the following three things. One, an ESR of less than 20.
ESR. What's that?
It's the erythrocyte sedimentation rate. It's just a very generic marker of inflammation in the blood. In OA, it should be low or normal. If it's high, we start looking for other things, like an infection or an autoimmune disease.
Okay, so a normal blood test.
Right. So ESR, less than 20. 2, radiographic osteophytes. That means we can actually see those bone spurs on an x-ray. Or 3, we see joint space narrowing on the x-ray.
So pain plus a normal blood test and an ugly x-ray. What about for the knee?
The knee is a bit more complex just because the joint itself is more complex. You need to have knee pain and see osteophytes on the x-ray. Plus, you need one of the following. Being over age 50, that morning stiffness lasting less than 30 minutes, crepitus on motion, bony enlargement, bony tenderness, or palpable warmth.
It really is a checklist you have to go through.
It is. And notice what isn't on that list, expensive MRI scans. We do sometimes check the synovial fluid from the joint, but usually that's to rule out other things like gout or infection. In OA, the fluid is viscous and has a mild white blood cell count, but nothing like the cloudiness you'd see in an infection.
So we've identified the enemy. We know the battlefield. Now let's talk strategy. Part 3, the treatment hierarchy. I imagine most people just want to pop a pill and be done with it.
And that is the instinct.
Yeah.
But the guidelines all emphasize a conservative approach. And there is a very practical reason for this. Think about who gets OA.
It's usually older adults.
Right. And older adults often have other medical conditions, hypertension, diabetes, maybe some heart issues. They are often already taking 3, 4, 5 other medications, so throwing a strong pain drug into that mix carries a lot of risk. The golden rule here is start with non-drug approaches.
It's the medical equivalent of, did you try turning it off and on again before you go out and buy a new computer?
Exactly. We absolutely need to exhaust the low-risk options first.
So what are those first steps? What does that look like?
First and foremost, education. The patient needs to understand that this is a chronic condition, not an acute injury. Then, lifestyle. If the patient is overweight, dietary counseling and weight loss are paramount.
Because of the load on the joint, right?
Physics is physics. The knee acts as a fulcrum. Every single pound of body weight places multiple pounds of force on the knee joint when you walk. Reducing that load is one of the only ways to actually slow down the mechanical damage.
I think people underestimate that multiplier effect. Losing 5 pounds feels small, but to your knees, that might be 20 pounds of pressure gone with every single step.
Precisely. It's a massive mechanical advantage. It's the best thing you can do for your joints.
That makes a lot of sense.
That's
What about moving the joint, though? If it hurts, my first instinct would be to stop moving it.
the paradox. You actually need to maintain the range of motion. Motion is lotion, as the physical therapists like to say. So physical therapy is huge. We're talking exercise programs, heat and cold treatments. We want to keep the muscles around the joint strong to support it. If those muscles atrophy, the joint itself takes even more of a pounding.
And I see a mention of assistive devices in the sources.
Yes. Canes, walkers, braces, even simple things like heel cups or insoles for your shoes. These all alter the mechanics of how that load is distributed across the joint. A simple cane held in the opposite hand can offload a tremendous amount of pressure from a bad hip.
And surgery, where does that fit in?
Surgery, like a total knee replacement or a hip replacement, is the end of the line. It's indicated only for severe functional disability or severe pain that is unresponsive to everything else we're about to talk about. It is the last resort, not the first step.
Okay, so let's say we've tried the diet, we're using a cane, we're doing the ice packs,
Yeah.
but the pain is still limiting our life. Now we're moving to part 4, the medicine cabinet. Where do we start?
For knee and hip OA, the preferred first-line treatment is acetaminophen, which you probably know as Tylenol.
Tylenol. It seems so. I don't know, basic.
It is basic, and admittedly, it might be less effective for some people than stronger anti-inflammatories, but it has a very specific profile. It is generally safer regarding gastrointestinal and cardiovascular events compared to the stronger stuff. However, and this is a big however, it has a hidden danger.
I noticed a pretty stark warning in the text about liver damage.
This is absolutely critical. Acetaminophen is well tolerated unless you take too much. It has what we call a narrow therapeutic window. An overdose can cause fatal hepatotoxicity, complete liver failure. And the scary part is how easy it is to accidentally overdose.
Because it's in everything, right? It's not just the Tylenol bottle.
Exactly. It's in your cold medicine, your nighttime sleep aid, your prescription pain pill that has kite set at the end of the name. If you aren't reading labels carefully, you can easily stack those doses and exceed the 4-gram daily limit without even realizing it.
And for some people, it's even lower than that.
Yes. If you are a chronic alcohol user or have any existing liver disease, that limit is much lower, or you should probably avoid it entirely.
Okay, so watch the Tylenol intake like a hawk. Now, what if Tylenol isn't cutting it? What's next?
Then we move to the NSAIDs, that's non-steroidal anti-inflammatory drugs, things like ibuprofen or naproxen. But this is where the decision tree branches pretty significantly based on where your arthritis is and, just as importantly, how old you are.
And this is the part I found absolutely fascinating, the topical versus oral debate.
It's a major shift in thinking for a lot of clinicians and patients. For knee OA, the guidelines recommend topical NSAIDs, so creams or gels, if acetaminophen fails. And here is the real kicker. They are preferred over oral pills for patients older than 75.
Preferred over pills. Why is that?
It's all about target acquisition. When you swallow an NSAID pill, that drug goes everywhere. It enters your bloodstream, it hits your stomach lining, your kidneys, your heart vessels. But when you rub a diclofenac gel on your knee, you get very high concentrations of the drug right at that specific spot, but remarkably low systemic levels.
So you're getting the pain relief where you need it without carpet bombing the rest of your body with the drug.
Exactly. You largely bypass the risk of GI ulcers, bleeding, and kidney stress. For an 80-year-old patient who might already be on a blood thinner, that safety margin is everything.
But if you do have to take the oral pills, maybe the cream isn't working, or it's for a hip joint that's just too deep for a cream to reach, what do you need to look out for?
You're walking into a potential minefield of side effects. We already mentioned the GI bleed risk. That increases significantly if you're over 70, taking high doses, or also taking aspirin for your heart.
Can you do anything to mitigate that risk?
You can. We often prescribe a proton pump inhibitor, a PPI, or a drug called misoprostol, along with the NSAID to help protect the stomach lining. Or we might use a different class of NSAID, a CoX2 inhibitor like celecoxib.
That's the one that's supposed to be gentler on the stomach.
Right. It is less likely to cause GI bleeds than the older NSAIDs like ibuprofen. But, and there's always a trade-off, it still carries cardiovascular risks. And interestingly, the text notes that the GI advantage of celecoxib all but vanishes if the patient is also taking aspirin.
So if you're on a baby aspirin for your heart, the fancy stomach-safe NSAID might not be as safe as you think it is.
Exactly. The aspirin interferes with the protective mechanism. It's a really complex balancing act between your heart, your stomach, and your joints.
Let's pivot to the hands for a second.
Yeah.
Because you can't exactly walk with a cane for your fingers.
Yeah.
What's the protocol there?
For hand OA, topical NSAIDs are again a first-line option. Diclofenac gel works well, but there is another first-line option specifically mentioned for hands, and that's capsaicin.
Capsaicin. That's the stuff in chili peppers. You want me to rub chili peppers on my knuckles?
The very same. You apply the cream to the joints.
And how on earth does that work? Does it just burn so much you forget about the arthritis pain?
It can definitely feel that way at first, but the mechanism is actually quite elegant. It depletes something called substance P, which is a neurotransmitter involved in sending pain signals from the nerve endings to the brain. Essentially, it drains the fuel tank for the pain signal.
Does it work instantly?
No, and that's the key thing. That's where patients often give up too soon. It can take up to 2 weeks of regular use, we're talking 4 times a day, to actually deplete substance P and provide real relief.
4 times a day. That is a serious commitment.
It is. And the second thing to remember, it burns. About a third of patients experience burning or stinging at the application site. And please, for the love of everything, wash your hands thoroughly after you apply it. Do not touch your eyes or put in contact lenses after using capsaicin cream.
Oh man, I can only imagine rubbing chili pepper cream into your eye. That is a safety tip worth remembering.
Indeed, it is an experience you only want to have 0 times in your life.
Okay, so we've done Tylenol, we've done the creams, we've tried the oral NSAIDs, but we're still in pain. We are now moving to part 5, second-line agents. What's left in the toolbox?
Now we're getting into more systemic agents with different profiles. One option is tramadol.
Tramadol. That's an opioid, isn't it? Or something like it.
Technically, it's a synthetic opioid analgesic, but it works a bit differently than something like morphine. It's often recommended for patients who have failed Tylenol and topicals, but maybe can't take oral NSAIDs because of their kidneys or stomach issues.
So it's a kind of middle ground.
Sort of. It doesn't have the life-threatening GI bleed risk or the renal failure risk of NSAIDs, but it has its own baggage. Nausea, dizziness, constipation are all very common. And there are 2 specific risks the text highlights: seizures and serotonin syndrome.
Seizures.
Yes, it's known to lower the seizure threshold.
Yeah.
And serotonin syndrome is a serious risk if you combine it with other drugs that affect serotonin levels, like many common antidepressants.
Speaking of antidepressants, I saw duloxetine on the list. Why is an antidepressant being used to treat arthritis?
Duloxetine is interesting. It's used as an adjunctive treatment, meaning in addition to other things. It's particularly preferred if the patient has both the musculoskeletal pain of OA and also some neuropathic or nerve pain. It helps modulate how the central nervous system perceives that pain signal.
But again, there must be side effects.
Of course. Nausea, dry mouth, fatigue. As we said, nothing is free in pharmacology.
What about injections? I feel like everyone I know with bad knees gets the shot. What is that?
Usually they are talking about intra-articular corticosteroids. We inject a powerful steroid directly into the joint space to calm down that inflammation.
And does it work?
It can provide excellent, though temporary, pain relief. It usually starts working in 24 to 72 hours, peaks around a week or so, and then the effect lasts for about 4 to 8 weeks.
That sounds great. So why not just do that every month?
Because steroids are catabolic, meaning they can break down tissue over time, there's a concern that too many injections could actually accelerate cartilage damage. So the rule is strictly to limit injections to no more than once every 3 months per joint.
Okay, so once a quarter at most. Now what about the other shot, the so-called gel shot? Hyaluronic acid. Some people call them rooster comb injections.
This is where the guidelines might really surprise people. The marketing for these injections is huge, but the text states that intra-articular hyaluronic acid is not routinely recommended for knee OA.
Really? I see ads for this all the time saying it lubricates the joint.
The evidence suggests a very limited benefit, if any, over placebo. It works for some people, but not reliably enough to be a standard recommendation. And for hip OA, it hasn't been shown to benefit at all. Plus, it carries a small risk of acute swelling or what we call pseudoseptic reactions. So despite the marketing clinically, it's not a preferred option.
Wow. Okay, while we are busting myths, let's talk supplements. Glucosamine and chondroitin. My dad swears by them. Every pharmacy has an aisle full of them.
And many patients do feel they get some benefit. But strictly speaking from the evidence, the source material notes that they lack uniform efficacy. They aren't particularly harmful per se, unless you have a shellfish allergy for the glucosamine, but they are not preferred treatment options because the data just doesn't consistently support their use.
So save your money, basically.
Or at least don't rely on them as your primary strategy to save your joint.
We've almost reached the bottom of the barrel here. What if absolutely nothing works?
Then we talk about opioids, real opioids. But these are a true last resort. They're reserved for patients who are high surgical risks, meaning they can't get that knee replacement and haven't responded to anything else. But routine use is severely limited because of the high risk of dependency, sedation, constipation, and especially the risk of falls in an already unstable older population.
It's a really sobering list of options. It just highlights why catching this early and managing the weight and lifestyle factors is so critically important.
Absolutely. Once you are deep down the pharmacological rabbit hole, every door you open has a pretty serious warning sign on it.
So let's move to our last section, part 6, evaluation and monitoring. If we are treating this, how do we know if we are winning? Is it just asking, does it hurt less?
That's certainly part of it. We use tools like visual analog scales for pain, but we really care about function. Can you live your life? Can you do the things you want to do?
What kind of metrics do you use for that?
Range of motion is a big one. Can you bend your knee further? For hand OA, we might measure grip strength. And for hips and knees, a really practical one we measure is the 50-foot walking time.
The 50-foot walking time, I like that. It's simple and objective.
It is. If you can walk that distance faster and with less pain, the treatment is improving your function, regardless of what the x-ray might look like.
And we also have to monitor for all those silent side effects we mentioned earlier.
Right. You can't just write a prescription for an NSAID and say, see you in a year. We need to check their blood pressure because NSAIDs can cause hypertension. We need to check for weight gain or fluid retention, which can be signs of kidney or heart strain.
And blood tests.
Definitely. We get baseline labs and then repeat them every 6 to 12 months. We're looking at creatinine for the kidneys, liver enzymes, and a blood count, a hematology panel, to make sure we aren't causing slow, silent internal bleeding from the stomach.
It really is a lot of maintenance.
It is. Managing OA is an active process, a partnership for both the doctor and the patient. It's not a one-time fix.
So let's bring this all together for the outro. We started this deep dive thinking OA was just simple passive wear and tear.
And I hope we've shown that it's a complex interplay of biology, mechanics, and inflammation. The body is actively trying to repair itself, but the breakdown process is just too fast, too overwhelming.
And the treatment isn't one size fits all. It's a clear hierarchy. You have to start conservative. You have to respect the side effects of medications, especially if you're older. And you have to remember that big aha moment. For those over 75 with knee issues, the cream often beats the pill.
And don't forget the importance of the diagnosis itself. That 30-minute morning stiffness rule is such a great, simple tool for anyone out there wondering if their aches and pains are OA or maybe something else.
I want to leave our listeners with a final thought to chew on. We talked about those osteophytes, the bone spurs, and you said they are the body's attempt to stabilize the joint, to lock it down.
Right. A last-ditch effort.
It feels like there is this fundamental conflict there. The body senses instability, and it tries to, in effect, fuse the joint to save it from further damage. But we, the people living in that body, want to keep moving. We want to play tennis. We want to walk the dog.
That's a really profound observation.
So are we fighting our own biology? The body is trying to stop the motion to stop the damage, and we are using drugs and therapy and surgery to force it to keep moving. The question for all of us is, how do we best work with that biological drive for stability without completely losing our mobility? It's not just about masking pain, it's about negotiating with our own cells.
That is the ultimate challenge of modern medicine, isn't it? Extending function beyond what our basic biology perhaps intended.
Something to think about the next time your knee creaks. Thank you for joining us on this deep dive into the mechanics of your own joints.
Stay curious and stay moving.
See you next time.